We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Hey, listeners, it's Nikki. Jess had to duck into the nearest phone booth to put on her superhero cape today. She's off doing really important infection prevention work. So I am solely taking on the pleasure today of talking with Dr. Jennifer Sanguinet, the Director of Infection Prevention at Sunrise Hospital and Medical Center and Sunrise Children's Hospital, and Gerard Marshall, Manager of Infection Prevention at Sunrise Hospital and Medical Center, about their article, Association Between Ventilator-Associated Events and Implementation of Acute Respiratory Distress Syndrome, or ARDS, Ventilator Weaning Protocol. So Jennifer has a doctorate in public health, a master's in business administration and healthcare management, and a bachelor's in information systems. She has her certification in infection control and is a fellow of the Association for Professionals in Infection Control and Epidemiology. She began her career in infection prevention as an administrative assistant at UCLA many years ago and has served in infection prevention in multiple facilities across the state of California. She's filled many additional roles in the past, including infectious disease response leader. That one sounds fun. I'd like to hear more about that. Employee health director and an information systems director. In 2014, Jennifer joined HCA as the director of infection prevention at West Hills Hospital and Medical Center. She earned the HCA Clinical Excellence Award for Central Line Associated Bloodstream Infection Prevention in 2016. She has been published in numerous publications, including AGIC, and has been privileged to speak on numerous occasions throughout her career, including the APIC National Conference and the Infection Prevention and Control Annual Conference in the United Kingdom. I love it when your job lets you travel. In 2017, Jennifer moved to her current position as Infection Prevention Director at Sunrise Hospital and Medical Center. She serves as the current co-chair of the Nevada Antimicrobial Stewardship since 2017. She has also just recently been elected as the president-elect for the Southern Nevada Chapter 035 and has been an APIC member for more than 25 years. Welcome. And Gerard has been in healthcare since 1979, starting as a registered respiratory therapist in the NICU and labor and delivery emergency response. He went on to gain skills in pediatrics, adult critical care, and rehabilitation for both pediatrics and adults. From 92 until 2019, he was in a director role for PT, OT, ST, and RT. Gerard presented at the 1985 National Nursing Convention on the advent of interventions for ventilator management of AIDS in the ICU and has spoken on asthma education for the NV Alpha-1 Antitrypsin Association. Is that the Nevada Alpha-1 Antitrypsin Association?
Yes, it is.
Okay. Gerard was also a non-hospital-based NALS educator at its inception in the early 80s. He was president of the Nevada Society for Respiratory Care for 2 terms and facilitated the initiation of Nevada State Respiratory Therapy licensure. He was an NSRC board member for 15 years. Gerard has been actively involved in student education and has been a field coordinator for PT, OT, RT, and public health students for more than 25 years. He holds a CIC board certification in infection prevention and control and has been active in the Nevada APIC chapter since 2009. He has been in his current role as manager of infection prevention at Sunrise Hospital and Medical Center since 2020. So guys, welcome. Those are a lot of credentials between the two of you guys. That's exciting. Happy to have you with us today. Yeah. Well, Dr. Sanguinet, I know you told me to call you Jennifer, so I'll do that from now on. Can you kick us off by telling us what prompted this study?
So having my colleague Gerard as a respiratory therapist, he is one of his primary responsibilities is looking at all of the ventilator-associated events through the National Healthcare Safety Network. And like everyone during COVID, we didn't know what was truly causing our increase in our ventilator-associated events during that time. In 2020, it was down in the 40s, and it continually rose. Initial thoughts were that this was related just to COVID, but the number of VAEs continued to rise each quarter beyond our COVID positive patients, which was really super concerning. In 2021, on second quarter, it went down from about 89 in quarter one to about 50 in quarter two. And we thought that was related possibly to the uptake of the vaccine and also related to some seasonal factors. However, the numbers in quarter three, in a quarter when it's summertime, truly did not match what it had in the past. In fact, it went above what it was in quarter one, which was a winter months, which is when you would expect some of the higher numbers. So that's really what prompted the investigation into what was going on. And, is there something new that we needed to do? Was it something that we just hadn't seen because we hadn't had the volume, or was it COVID? What was it? We didn't know.
Right. Yeah. And there's so many changes that have been going on. That's concerning for sure. So, Gerard, can you tell us what some of the risk factors are for developing a ventilator-associated event?
Well, the ventilator-associated event is a monitoring system NHSN uses definitions. So if you trigger the definition, you have the risk. So if your FiO2 goes up or your FiO2 goes down, your PEEP goes up, your PEEP go down, those ventilator changes put you into a situation where you have a risk to trigger the VAE algorithm. And so once you're in the algorithm, it's the primary driver is weaning or turning up the needs after somebody is stable. So it's an indicator that they've come to say, well, this may be ventilator-associated pneumonia. So there's steps that go through it. And, there's other risk factors like trauma and, just seeing the whole picture and deciding that these patients that are being weaned or are being increased are at a higher risk.
So, you've mentioned VAE categories, the ventilator-associated event categories, Gerard. Can you describe those categories and how they're determined?
Yes. So initially you have a VAC. There's VAC, there's IVAC, and there is VAP. And it's a PVAP. It's a potential ventilator-associated pneumonia. So VAC is a ventilator-associated condition, and that's when you trigger either an increase in FiO2 of 20% for 2 consecutive days after there's been a stability for 2 days, or an increase of PEEP of 3 for 2 days after there's been a period of stability for 2 days. So basically, if the VAC happens, then you have the ability to look at whether or not the patient has an infection. So if the patient has an infection, that means that there's going to be treatment. So if there is treatment with an antibiotic during the window, and the window that we look at is those 2 days of stability, the day of the event, and then the 2 days after. So you have a little 5-day window. So if in that 5-day window you have 4 days where an antibiotic is started and it's continued for 4 days, they call that a qualifying antimicrobial. And so you have to have something else that's a sign of an infection. So we look at the typical signs of infection, the increase in temperature or the increase in white blood cell count. So if it's over 12 in white blood cell count, or if the temperature is 38.1, then you can, or 100.5 greater than, then you can, you're getting an IVAC. So you go from a VAC to an IVAC. So now you've satisfied those 2 levels. If you satisfy IVAC, now you have to look at PVAP. So what are you looking at? Well, we've got signs of an infection. We're treating of an infection. do we have a positive culture that's within that window? And that's what we're looking for. We're looking for a bronchial lavage. We're looking for a suction, a clean suction, a bowel, something that's going to give us that. There's also other factors. You could get a tissue sample from the lungs. You could get a lot of there. It's a whole algorithm that lists it. Those are not as often as you're going to see a sputum culture, a tracheal aspirate, a bowel, or a bronchial brushing. One of those things are usually the way that you get your PVAP. So when you get that positive culture, so you've got your trigger of your FiO2, your PEEP, you've got your qualifying drug that you're giving, you've got your other trigger, either fever or your leukocytosis or leukopenia you could also have. And then you could also have low temperature or fever. And then if you have that positive culture, then you have a potential ventilator-associated pneumonia. And those were the things that we were looking at because, we were in a big hospital. This is a 800-bed hospital. And we were bigger than 800 when COVID hit. So we were up to our eyes in work every day. We were working, 18-hour days every day. And when we came out of it, because, in the summer when we got rid of the original and we were into the what was it, Delta, the second one?
The second one.
We came up for air, and I'm trying to catch up on all the stuff that, just not saving lives, saving staff, and making sure we had all the ways to deal with patients. We started looking at all this stuff, and we were inundated with VAEs. And I'm telling you that a lot of them were very close to being triggers, just missing it by a day here and there. So these numbers don't reflect how many really trigger potentials there were that we were looking at. So we were just in the middle of looking at all these categories saying, wow, there's something going on.
Well, I will say in the article, you guys have a great algorithm on ventilator-associated events and how you can categorize it as a VAC, IVAC, or PVAP. So I highly recommend everybody go to the article and cut that out and pin it on your little cork board in front of your desk if you always forget the definition. So what are some of the key components of ventilator weaning to reduce the risk of adverse patient events?
Well, when you're weaning a patient, you have to recognize that each patient is not in a cookie cutter type weaning. And so one of the key components of ventilator weaning that we had always seen was that there was a team of people that were doing the weaning that really had a ton of experience. And so they were following a process that worked. And we didn't have a lot of ventilator-associated events. But when COVID hit, it really changed the dynamics of who was administering the weaning process. And so we were in a situation where we're trying to figure out what's going on because the behaviors that we were seeing were not necessarily what we were expecting to see. So that is in a weaning process. If you're not following a protocol, if you're not following a process, if you're not following what is expected, then you can have adverse patient events. So what we were seeing is an influx of LIPs that really didn't have a lot of experience dealing with patients that had a injured lung. So ARDS is an injured lung. And so that was the big risk. We had to find a way to wean that was using like ARDSnet. We looked at that. Are they following this? We were trying to figure out what tables they were using, what plans they were using. So what we did was we started to contact the intensivists and ask them, what are you doing? And so what we found was that they were weaning like they were dealing with normal lungs, and they were dealing with ARDS lungs. They were dealing with lungs that had acute lung injury. So we were not only seeing them not necessarily following the PEEP the little table we have in there with the PEEP algorithm where we say if you're on 30%, you have a PEEP of 5. If you're on 50%, you have a PEEP of 8. If you're on 60%, a PEEP of 10, 70, a PEEP of 12, and it keeps going up. Well, when you see that people are not following that, you're bringing in variables. You're putting a lot of oxygen into a lung that's not fully inflated so that it can cause harm. There's a lot of free radicals. There's a lot of things that happen when you're on high oxygen. So we were looking at this going, wow, they're not necessarily following it on the way up, and then they're not following it on the way down. They would stabilize a patient with PEEP and oxygen, and then they would just turn the PEEP down. So we realized that some sort of protocol needed to be put in place so that the team would follow the process. And by follow the process, I mean give them something that they feel comfortable with, that they can refer to, that is a evidence-based plan. And so we approached the team, the respiratory team, the intensivist teams, and we knew that we had to somehow get them to start educating their staff. They have to follow the protocol. And we knew that as a team, we needed to meet and come up with a plan that not only set goals when we're setting the patient up to make sure that we didn't do harm with the oxygen, but we also needed to protect weaning them too fast so that we didn't have lung collapse.
Yeah. So tell us more a little bit about that oxygenation goal table and how that's used.
Well, if you keep the lung open with pressure, then your oxygenation happens because the lung functions great when it's open. It doesn't function great when it's collapsed. So if you look at the table and you notice every time the FiO2 increases, you increase the positive end expiratory pressure on the ventilator. So that what you're doing is if you need more oxygen, you need more pressure because you need to keep the lung open so that it can exchange the gas. So on the table, if you're on 100%, you should be on 18 of PEEP to up to 24. And so that table tells you that 5 is for low FiO2s up to 40%. And then you just keep increasing the positive end expiratory pressure as you increase the oxygenation. That's a problem because most people are comfortable with a PEEP of 5. So you could see a PEEP of 5 with 70%, which realistically is not going to be a good thing, because what most people don't understand about running a ventilator is oxygen is a consumable gas. So if you don't keep the lungs open and you start getting up into the higher oxygenation and the patient is in a really insulted state, the body starts to dump the oxygen that's in the alveoli into the bloodstream to deal with the hypoxia. But what happens is there's not another gas in there to replace it because the percentage is all oxygen. So the nitrogen that's usually the scaffolding of the lungs keeping it open, it's not there. You got pure oxygen. So you have a lot of lung collapse. So that's why you use the pressure. So what we were finding is that correspondence when we were reviewing the cases, it was not happening. They would stay for 2 days, 3 days, 4 days with low PEEP and high FiO2, and then they'd realize what they were doing. And then they'd increase the PEEP really fast to try to catch up. And that triggered a VAE.
I love that we're getting into the biology of it. It's been a long time since a lot of us probably looked at that. So thank you for that. And, there's always a lot of people involved in the development of a new protocol. And, excuse me, let's back up. Sorry. Okay. So, Jennifer, there's always a lot of people involved in the development of a new protocol. So who was involved in it and where was the supporting evidence derived from?
So as you said, it takes a village to implement a protocol, especially in a facility of this complexity and size. And so obviously the entire infection prevention team, even those we have a few more junior members who participated with us. We had a couple interns in the department at the time helping us do some of the data research. And we also included, it was complete multidisciplinary team, our respiratory therapy director, supervisor, and staff. The IP, the critical care medical staff, was a key component to this. Obviously, support from our chief medical officer and our associate medical officer, and the nursing leadership in our critical care areas, because they were the ones that we knew were going to help keep eyes on this, because this is a big place, but funny, there's only 5 of us in infection prevention, so we couldn't be standing up there watching all of this going on. We needed to depend on the eyes and ears at the floor level. So it was quite an undertaking with a large team, a lot of moving parts. The supporting evidence, we didn't just use one single thing. We went through ARDS-Net is where we started with some of the goals that we should have. The American Journal of Infection Control, Annals of Intensive Care, the current CDC guidelines that Gerard shared about the VAEs, respiratory care, clinical infectious disease. In addition, we had an interdisciplinary team of subject matter experts who were very familiar with this from other facilities in their past lives. And so that helped us with some guidance as well.
Yeah, you talked about 5 of you doing not doing all of this, but there's 5 of you in the department, and it takes a village. Resources are often a consideration when you're initiating process improvement work. So what were the necessary resources to implement this protocol?
So this was not an easy thing to implement. It very complex. We actually started this almost a little over a year before we were able to get it passed through all of the checks and balances that it need to go through. The improvement was for more intervention on the part of the respiratory team, where the actual patient care was needed. They needed to have it in their hands versus it being waiting on an intensivist to make that decision when they did their rounds every day. Mm-hmm. And the investigation for all of the data mostly was on the infection prevention team resources. And as I mentioned, we are fortunate. We have a really good partnership with our local university, UNLV, and we take full advantage of interns who are interested in infectious disease and come and join us for about 5 months at a time. And we had 2 at the time who were very interested in this, and both of them are listed on the article as authors because they worked very, very hard on helping us do the data, getting all the data, because it's a lot. So, it takes a village. The resources, we couldn't ask for extra resources to do this, but we knew that it was something that was super important. And we just kept hammering at it until we could figure out a solution.
Yeah, it's not fun sitting there looking at a chart and figuring over days whether or not they followed the protocol. So you have the protocol, and then you just have to look at numbers and say, oh, they didn't. Oh, they did. 1,500 patients.
Oh, man, that is a lot of resources. Lots of resources and lots of digging. So hopefully you had a good electronic health record to assist in that instead of paper charting or, yeah.
Thank goodness. Good. It's not the 80s. Woohoo.
Yeah. So there was a retrospective investigation of the 1,233 ventilator periods that were conducted. Can you tell us a little bit about that and how the periods were defined and who did all of that investigating, all of that digging?
Yeah. So the ventilator periods were defined based on timeframes. So we wanted to go enough before we saw the issue to make sure that we had a good comparison. And so we did Q1 of 2020, and we went all the way through I believe it was Q4, December of 2021. And it was about 1,200 period, so to speak, because it's not patients. It's how long is a patient on a ventilator. And a period, it counts if a patient's on a ventilator for 4 or more days, because you have to be 2 stabilizing and 2 going up or changing to make it to be a VAE.
Sure.
So that's how we define it. So it's the 4 day, at least 4 days of ventilation. Fortunately, most of that is something that we do review every quarter because we're looking for our VAEs anyways. So it was just a matter of going back and looking at all the ones that we said, no, this isn't a VAE, and also determining those ones to say, well, why wasn't it a VAE at that point? So we had to go back and look at, did they follow the protocol versus not following the protocol? And that, fortunately, I couldn't have hired a better person pre-COVID. Gerard started with us in 2020, and a respiratory therapist coming and starting in IP in 2020 when COVID was hitting was like, my prayers were answered. But
so I take it that was the beginning of 2020 then.
Yes, he came in February.
Oh my goodness, that is a trial by fire.
Right. But it actually was quite prophetic, because he recognized very quickly what was going on. I mean, when we had those numbers continued to go up and he was going back to look at some of that stuff, it was pretty easy to identify that there was something going on. So just looking at all of the ventilator periods, determining, and Gerard taught all of us, myself, my other manager who's been here for 40 plus years didn't know this either, and the two interns, all of us, how to read that table and what that meant, and to determine whether or not it was followed. And then also to do the same thing after the implementation, which was around March of the protocol was initiated, to see if that had the difference. And that was what we were looking at, to see whether or not, there was a difference after implementing this protocol.
That's too cool. Too cool about him coming at that time and doing some education, because you come from a different background, Gerard. So that's always helpful to have somebody who's got that vast expanse of knowledge. And Gerard, while I've got you, what do you think some of the reasons were that, what was it, only 66%? I think it was 813 periods out of 1,233 followed the protocol. What do you think some of those reasons were?
Well, human factors were a big portion of it. We had a significant increase in the need for ventilator use, which significantly increased the need for intensivists. And they weren't all familiar with the ARDS protocols. So everybody was dealing with a fire hose of sick patients. We had patients, at one time we had 267 patients who had COVID that were in isolation in this building. And we had ICU, which is about 100 beds of ICU beds on 2 floors were all full. So then we started to put the ventilators in other places. And so we had like ICUs popping up in satellite units. And it was amazing how many we had. Well, there's just the intensivist staff were overwhelmed. And a lot of the people that had been intensivists for a long time and they were near retirement, they checked. They said, well, retirement, that sounds like a good thing. And so they were replaced with less experienced people. So there's that factor. The staffing was new. So a lot of the nurses were new. A lot of the RTs were new. So everybody's new and everybody's dealing with this stuff. And then you come in, and initially I was curious, why aren't we using APRV? Well, this is a novel ventilator mode to some people. It's not a novel mode. It's been around for 20 years in heavy use in certain areas. But here it was just starting to get its foot in the ground. And there was a lot of the physicians were, okay, we're going to use this. And it really helped previous to COVID. It helped bring down the numbers. But then when you throw that into what we were dealing with, we realized that we had to do a lot of education. We had to work with the people that we had. We had to work with the new people, and we had to get them to buy in on the protocol. So I think what you see is that a lot of the people were just comfortable doing it the way they were doing it, and they were overwhelmed. So what we did is we reviewed everything, and it was real time. So we would review the data, and I would have the respiratory therapy team coming up to me and saying, I think you're going to get VAEs on this patient, because the protocol's not being followed. So I would tell them, you need to personally talk to the intensivist. And so it was day to day, LIP to LIP, different things. And so we had a situation where we would get compliance, we wouldn't get compliance. That's human factors. But we used our multidisciplinary teams. We went to the rounds. We talked to them. We got the RT director, the RT manager, the leads, the charge nurses, everybody looking at, hey, when you got somebody on a PEEP of 18, the next day they can't be lower than a PEEP of 16. And you're in the meetings with them. That's the protocol. We're going down slowly because we've stretched the lungs out and we don't want to lose our surfactant and collapse. So we're going to go down slowly. So this is the kind of stuff that you have to have multiple people watching when something new is coming in. And you know, when you're so busy, you have to realize we're having ICUs and satellites.
Yeah.
So you may have a charge nurse there with people that don't have experience. She may not have that much experience. He may not have that much experience. And then an LIP walks in that really doesn't have a lot of experience. They may be a super nurse practitioner. They may be super PA, but they've specialized in going in and relieving the teams. So now they're the primary doctor. Now they're the primary LIP. Now they're the one that has to make the decisions. Right. They have to make sure that everything's working. So I think that it was the collaboration that eventually brought it up to 60%, because initially it was much lower than that. It was really a team effort. You know, it was
you've got a clean slate too. You know, you've got new practitioners that are kind of like sponges and malleable during that time. Like, please give me as much information as I can. So again, prophetic that you've got such an educator on hand to help do that.
Yeah, we were I agree. We were really lucky. And most didn't look at it, I don't believe, as having all of those new staff, new respiratory therapists, new LIPs as a great thing during COVID. For this particular situation, what you just stated was actually a good thing, because they didn't necessarily have all of those preconceived notions about what should be done. And we could actually show them the evidence and have them help us make an educated protocol and direction for taking better care of our patients.
Right.
Yeah, the older people that have been here a long time, they were skeptical that it would get in place. They said, well, I'm not sure that people will listen to you, but we're glad you got this. We're glad that you're putting the RTs with a protocol so that we don't have to wait 2 hours for the doctor to call us back. We can make the changes. And that is really important when you're looking at somebody crashing.
Okay, so the investigation determined that 66% of periods that utilize the protocol, 6% or 49 periods were complicated by a VAE. And of these, 53% developed into a VAC, 37% into an IVAC, 10% into a PVAP. So what do those results tell us about the population that received the protocol?
Well, what it shows us is that the numbers that we were looking at, where we were just growing and growing, they started to rapidly decrease. And so instead of having 39 VAPs, only 10% of a lower number got VAPs. So overall, our numbers just plummeted when we put the protocol in place. So when you're looking, numbers are so hard to picture, but when you have a small number of patients getting the triggers, but you're still having 10% developing PVAPs, you know that you have a sick population. There's no way around that at a hospital like ours, we're not going to get PVAPs. We have a sick population. We have a trauma center. Trauma is a big part of this ARDS. It's not always COVID. It's trauma. We have a neuro ICU. It's all these things that flood the lungs. But what we were seeing, we saw that the triggers after the protocol was in place, they went down markedly. That after they started weaning, when they were dealing with somebody who's really sick on a slow step, we got down to what is an expected number of patients for a population that we're looking at. So I don't think we're ever going to get down to no PVAPs, but get down to a situation where this year we have it's like.
Yeah, it's a very low number.
We projected that we would have.
If we're 10 or 11.
We would have, if we did a great job, we would have 15 and we have 11.
Yeah.
So it's even bringing more and more surprises, and it's just more and more comfort with it. So as the staff collaborate more, it gets better and better.
Right. No, that's wonderful. That's great news. Have you guys fully implemented the protocol as a result?
Yes, we have. And, outside of the human factor or new respiratory staff who aren't fully trained yet, same things that happened during COVID, you're going to have that little learning curve. But outside of that, the majority of them, and we do, Gerard, when he does the VAEs now, he actually just marks it as he's going through them. And the number that are not following the protocol are lower and lower and lower every time, which is a good thing. And the ones that we do find generally have not followed the protocol for one reason or another, whether it's because the physician made that, decision, or the new respiratory therapy, whatever the case may be. But again, our numbers have just completely dropped.
Right. We're looking at like 50% of the VAPs that we currently have, they didn't follow the protocol. So that really tells you that.
It works.
Yeah.
Did you all make any edits or additions to the protocol as a result of the findings?
Yeah, we really didn't, because it worked as intended. And we kind of used, our Q2, Q3 as our guide in just pure numbers for our VAEs. And, in 2020, like in the throes of COVID, it was like 42 and 62. Those were the numbers. And then in 21, Q3, it was 94. Which that's, again, the summertime. And then we implemented it in Q2 of 2022, fully implemented then. And Q3 in 2022, we had 33. It was a third of the ones in 2021.
Wow.
And then Q3 of this year, it's also lower than that, a couple lower than that, So, we continue to drop every quarter because we can easily focus on those new individuals who haven't had the full-on education that the rest of the staff have had, or the experience with it. And in other words, we've maintained our normal pattern at a super marked reduction in VAE, and continue to just, hammer at those few individuals that may not have the education they need.
Right.
One of the things that's really funny is that some of the people in the meetings when we were setting it up that were the biggest antagonists to us putting it in place.
Yeah.
They're really big proponents and have actually stopped me and said, that is really a great thing that we're doing now. And I'm like, yeah, you are doing a great job. That's all I do is every time. You guys are doing a great job. I'm the cheerleader.
Well, congratulations, you all. That is a remarkable improvement and a lot of work that goes into that. So on behalf of your patient population, thank you for sharing all that work and doing it. Any takeaways for the listeners?
From my perspective, I think, infection preventionists are a special breed.
Yep.
We're a never say die, never take no for an answer, never you can't do it for, because this honestly took us probably 2 to 3 years total time to get where we are. And it was a lot of no's. So, I think just continuing to keep bringing it back up, also get with your partners, find the experts in the field. I personally don't have a background in respiratory therapy. There was no way I could have done this without Gerard and, his expertise. And, obviously all the people on the team include everybody. But I think that's the biggest takeaway is that, the ventilator-associated events are not necessarily completely preventable, but a probable or possible pneumonia, for the most part, is, if you can implement the protocol fully and make sure that everybody's following it.
Yeah, I think that for me coming here, it was unbelievable because I had been from a 24-bed place where, wore a lot of hats, and I came here and I was going to be focused on this. But what I found was this building really pulls everybody. You may be in a meeting and all of a sudden somebody's asking you to do something. It's not necessarily part of your job, but we found that we were pulling from everybody to get this done. And what we did was create more camaraderie between the RTs and the doctors and the RTs and IP, and everybody helped. And I have to say, just to reiterate what Jennifer said about the students from UNLV, you see 1,200 periods there. We looked back, way back before, at all the patients. So we looked for a couple of years to get all the data to look at the windows that we were going to do our comparison on. So it was a ton of stuff, and it was really great to see the teamwork. Yep. And, to have Jennifer, somebody that is an IT expert, be able to compile all this and to help us with all the equations and everything, it's so valuable. It's a great team.
Well, Jennifer and Gerard, I thank you very much for being on the show today and sharing all that wonderful research and information. And you guys come back anytime.
AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AGIC, and APIC staff Shanina Knighton, Chris Ruiz, Bobby Gulshan, Christine Miller, Kaylee Deaton, and Kelly Lynn Russell. We work in partnership with Human Factor and audio tech Blake Alphin. To hear other AGIC podcast episodes and to access information about this podcast and the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AJIC scienceintopractice.org.